Good morning. I'm a surgeon with the mHealth Fairview Wound Clinic in Minneapolis, Minnesota, and an adjunct associate professor in the Department of Surgery. I'm the medical director of our wound clinic, and one of our areas of focus in our wound clinic to accelerate healing is identifying interstitial edema and lymphatic dysfunction. So in the differential diagnosis of lower extremity edema, we have to think about organ dysfunction. So congestive heart failure, renal failure, people that are on dialysis tend to have lower extremity edema, people with liver dysfunction, history of deep venous thromboses, trauma. And then when we start to get into other broad categories, we always have to look at medications. So one of the specific medications we look for is Norvasc, or also known as amlodipine. Other causes, if we look specifically at lymphedema, there can be primary and secondary. So primary is always genetic, and genetic forms can appear immediately at birth, like Meigs syndrome or Milroy syndrome. There can be lymphedema tarda, which then occurs later in life. And then there can be a lymphedema praecox, which tends to happen kind of in the teens to 20s. And I think there are many people that have a genetic predisposition to developing lymphedema that sometimes it is a tipping point in the course of their life where maybe they're just on the edge, they get a knee surgery, and now they've got lymphedema that just doesn't go away because the trauma of that surgery resulted in interruption or trauma to the lymphatics. And of course, the other probably most significant aspect in the United States is what I would call LOVE, or lymphedema of venous etiology. So in the United States, venous insufficiency affects somewhere around 30 to 35 million people. And I would challenge my colleagues that I think we under-recognize and under-treat edema within the legs. And if we look at patients that are hospitalized, it's estimated at minimum 30% of patients hospitalized have lower extremity edema, which puts them at risk for further complications during that hospitalization. This has an incidence of somewhere between 11 and 13% of all women in the United States. So the predilection is women, and we have this incredible amount of women in the United States and actually worldwide that are affected by this painful fat disorder. So it causes discomfort. It's very uncomfortable, and most physicians don't even know about the diagnosis. Therefore, women come in and say, look, my legs hurt and I'm having difficulties and I'm gaining this unsightly weight from my waist down. And yet when I go to lose weight, it all disappears from my waist up. And so if we look at women inappropriately and say, well, you just need to eat less and exercise more, that's a very shaming situation, and it's not the correct diagnosis, and it actually won't treat the underlying disorder. So using compression, using exercise, managing muscle mass, using manual lymphatic drainage, so getting your certified lymphedema therapist involved. There is now evidence for utilization of lymphedema pumps for management that are equivalent to that help assist with manual lymphatic drainage-like situations. And the other really important thing, and Steve Dean taught me this, was micronized purified flavonoid fractions. When you're seeing these patients in consult or with new conditions, always go back and think broadly. So start systemically and then start to work down. So when we're looking at the legs, remember to think about if it's bilateral leg swelling, has something changed from a heart standpoint, liver standpoint, renal standpoint, thyroid standpoint. All of these can cause lower extremity edema. So start broad, always go back and look at your differential diagnosis, and then the differentiating factors with lymphedema, chronic venous insufficiency, and lipedema. Well, with chronic venous insufficiency, you're looking for, have the patient stand. Do they have venous varicosities when they stand? You're not going to see it if the patient's sitting. Take off both shoes, both socks, and examine the patient. History of deep venous thromboses, history of pulmonary embolus. If it's a left leg swelling only, think about May-Thurner syndrome. There may be compression of the left common iliac vein by the right common iliac artery. So don't miss that diagnosis in isolated left lower extremity edema. And then look for staining the skin, family history of varicose veins. So that's going to help in the venous insufficiency side. On the lipedema, the classic is painful legs. It gets worse as I age. I'm gaining weight from the waist below. I try to lose weight, and the only place I can lose weight is in basically my waist up. I just can't lose the weight from the waist down. And it's 99% of these patients are women, and it tends to be, there's a strong genetic component, so family history. And then with lymphedema alone, this is really where, even as much as I like to think I know about lymphedema, I'm relying on my colleagues. I involve physical medicine and rehabilitation colleagues, because I think lymphedema itself does get complicated. And I think we've got to treat these patients in a collaborative fashion. Well, given that we live in a gravity environment where all fluid wants to flow to the lowest point. So within bodies, your interstitial fluid, lymphatic fluid, which comes out between that transition from artery to vein, is always going to go to the lowest point. So typically when you sleep, that edema resolves or gets improved. When you stand up, and typically within an hour, that fluid starts to gravitate towards the ankles because of the hydrostatic pressure differences. This is what makes graded compression, grade 1A evidence for treatment. It is the foundation of all treatment. So as you utilize graded compression garments, you got to look for quality, consistency, durability, and proper fitting. So Sigvaris has the best garments that are out there. The attention to detail is so significant. The quality, nobody matches the quality. You need to work with somebody that can properly assess the leg, can properly measure the leg, can properly match your leg to the correct garment for graded compression. Because if you have the improper garment on the leg, the adherence rate or compliance rate from the patient is going to be very, very low. And therefore, you're not going to get the outcomes you expect. Ultimately, a garment won't do everything. You still have to do clean nutrition. You still have to do the exercise component. You still have to look at medications and really treat this on a daily basis. Ultimately, the best outcomes are going to be having high attention to detail and educating families around how to manage this in the long run. So I think we have to find ways to treat patients where they're at to get the best compliance rates, but they've got to have a high quality garment that is suitable and has really good outcomes. We have to be very cognizant and very aware of the presence of edema in the lower extremities. And I think we could do a better job from a clinical standpoint of making the diagnosis.